Valentine's Day and happy Galentine's Day. And I hope that you're having a great day. And hearing that the weather up north was something else, I'm particularly, I'm extra grateful that people are here. I think I hadn't realized that. In fact, I would say that I live in Albuquerque and I was just thinking about I work in the western part, so I wondered what the weather was like there. Anyway, I thought that when we get going, I know that I've had a lot of fun with having some um, in the beginning of the calls, having a little bit of a like an icebreaker, and I think those have been a little bit fun. And even though it doesn't mean that we truly know each other, I do find that it's a little bit fun. It creates a little bit of psychological safety and some rules that I'll ask people to consider broadly when we do this, because we want people to have the psychological safety to be able to contribute to be able to contribute, period. And to remind us all to have that open minds about the questions and the suggestions that come from others, that comes from that, not having that concern that one would be judged. My light is doing something funny and blinking. That's not your screen, so I'm going to turn it off, but wonder if that means that it's too dark. Just a disembodied voice. Okay, thank you. So with that, then maybe what we'll do instead, in the spirit of Valentine's Day, that we'll ask everybody, and I'll go maybe as I see you on my screen, to say your name, to say your pronouns, and then also to say if, I'm tempted to say if you're like a dark chocolate person or are you a sociopath, but I think that really doesn't do a good job to create community. So so maybe we'll say chocolate or roses. Does that sound okay? Or you can say something else. Chocolate, roses, or something else. All right. Thanks. And then with that, also the reminder that there's everybody here is here because they belong here. Also that people have different advanced and terminal degrees. So I'll ask that we all refer to each other by our first names and ask you to go with that. So with that spirit, I'll start. I'm Eileen, she, her, hers. And at dark chocolate, I think I put my cards on the page, my cards out there. And the next person that we'll go to will be Alan.
Okay, happy Valentine's Day to everybody. I'm Alan Plymill in Deming. I'm a he, him, and happy to be here.
Happy to have you here. Anything for Valentine's Day? Do you prefer chocolate, roses, or something else? Chocolate flowers or something else?
Oh gosh, I think I would go with roses.
That's sweet. Thank you. And how about Haley?
Hi, everyone. Haley Peterson. I'm with New Mexico Department of Health in the substance use epidemiology section, and I'm torn, but I guess I'll go with chocolate.
Thanks. And Katie?
Trying to find the mute button. I'm Katie Wickowitz in Albuquerque, but drove in from the East Mountains and had a skating rink of a road with almost 6 inches on it. So we got hit in the East Mountains today. So she, her, and definitely dark chocolate.
Thanks. And I think you go by Mateo. Is that correct? Matthew? Yeah, okay.
Yes. Yes, I'm a chocolate fiend, so all the chocolate all the way. Only if the rose was chocolate. Everything except white chocolate, which is not chocolate. So based on your comment of the sociopath of white chocolate people, go eat real chocolate. Yeah, and my Valentine's activity is to go watch Magic Mike. It's not exactly my choice.
Okay, I'm going to pull it back together to to be a professional, or to do my best to be a professional. And Andrea?
Good morning, everybody. Andrea Sundberg, she, her are my preferred pronouns. Valentine's Day, I definitely am. I love chocolate and I like flowers, but on Valentine's Day, I always require pasta and garlic bread because I've been married for over 30 years, so it doesn't matter what my breath smells like. So
Keeps the vampires at bay also too, so good call. Yeah, good call. Dominic?
Good morning, everyone. Dominic Zerlo with Department of Health Medical Cannabis Program, and he, him, and his. And this is really actually a very difficult choice for me because part of my former life and side business on occasion is actually as a chocolatier. And also, I love to garden. So I'm going to go with chocolate roses because that way I can have the best of both worlds.
I like it. Expansion, right? We don't need to have horse choice execution, right? You're redefining your
Right.
own path. I like it. I like it.
Exactly.
Yeah. I think that Matthew Clark goes by Matt.
I do go by Matt. And sorry, I'm in multiple places right now. We have a little bit of an emergency going on. But I go by, I would say milk chocolate because I cannot stand dark chocolate. It is way too bitter. Of course, probably fits my personality lately. But yeah, so there you go.
Well, I'm sorry to hear about the emergencies. I hope that everything ends up being okay, and I hope that whatever milk chocolate crosses your path today, that it helps.
Yeah, thank you. We're dealing with our PSAP is going down with no battery or generator backup working.
Goodness.
So
Okay. Goodness. Wow. Okay. Good luck. I think that Elizabeth goes by Libby.
You are right. Good morning, everyone, and thank you for being here. Libby Bissio, health educator with the medical cannabis program, she, her, hers. And, I'm really a donut person for Valentine's Day. Lots of, while I do like dark chocolate, I would prefer just like a bunch of donuts.
That's a pretty good day.
Yeah.
Yeah. And Eleni?
Hey, good morning, everyone. Eleni Bukovalis, she, her pronouns. So many good suggestions. Chocolate and flowers are great, and pasta. Pasta is amazing. I would maybe pick pasta over chocolate. It's so good.
Nice. And I think I had seen Gary's name, but now I don't see him, and I don't know if that's because of my settings, or did he have to drop off?
Yeah, I'm not sure what happened there, but it looks like he's having some technical issues. So
Okay.
hopefully he'll be able to join back shortly.
Okay, thank you. And then I know that before there had been, I think that we were able to get everybody who I could see. Is there anybody who I don't see who we didn't get to?
I think you got everyone.
Okay, all right.
Yeah.
Thank you.
Great job.
Thank you. This group is the nicest group. Well, thank you, everybody. And with that, then I also wish to provide an update. So, of course, that I'm the vice chair, not the chair. That Martin is our chair, but that he did have to step off the committee. And maybe at the end of the call, if we actually maybe I'm going to ask if people are okay if may we do a wave that I can send to him. So that he knows that we're thinking of him. He had some health issues that came up that affected his ability to continue on this work. Would you consider on the count of three a big smile, consider a wave if you want to? Okay, 1, 2, 3. Thank you, you're the best. I'll send that to him with our thoughts. And with that, then we'll start the formal, a different part of the agenda, right? And we'll hear next on the update from the medical cannabis program, and I will mute myself.
Okay, thank you, Eileen. So we don't really have a whole lot of things that are going differently right now, and I'm not going to go through the data as far as going through each part of it. You can each see that if you want to visit our website. We have on our educational material page, we put the monthly stats up every month rather. And we do still see the continued trend of fewer patients enrolled in the program at the moment, but it's still along the trajectory that we had predicted with regard to adult use starting back in April. We haven't yet hit the lowest point of that. We anticipate that will probably happen in just a few more months. And then our numbers will start to rise back on up. The one thing that I would like to say is we have been doing a big effort to move all of our processes online. And this has actually been really helpful for many of the patients, especially patients who, so long as they have internet access, are in rural areas. And then, of course, we're working on alternatives for individuals who don't really have internet access and finding other resources for them, such as community centers, libraries, other local places that actually do have access for internet so that people can go and actually complete it there. But what we're finding is many of the providers, once they get enrolled to register people through the online portal, they're finding it so much easier. It works very well, especially with regard to telehealth. So if we had a situation like we had in the last 3 years, providers could still be seeing their patients on a regular basis and actually getting them enrolled in the program without necessarily having to have some of the contact that might be fearful, especially for people who are immunocompromised in other situations with regard to the program. So that's moving forward, and we are on target for our goal of switching to fully online by April 1st. Right now, we have over 23,000 of the patients have actually enrolled in the system. So that's quite a few. And we really only need to have about 3,000 each month, because not all of the patients have to be enrolled by that April 1st deadline. Just those patients whose cards start to expire or who need to do renewals, because then as their cards expire, they will continue to, the providers and the patients will continue to enroll. We also have what we consider to be about half of all of our main providers who are doing certifications already enrolled in the program or in the online program. So that's pretty good. I mean, it's about 150, and we figure there's about 300 providers who certify people regularly. And sorry that my phone keeps going off, everybody, in the background. It's actually from Gary saying that he is having problems and he keeps losing connections, and he's trying now on a third device. So he'll get on once he can. But sorry about all the beeping in the background. And that's pretty much our big focus right now, because we think this is really going to improve access for many of the patients to be able to enroll in the program, reduce costs for them. And then the other thing that I just wanted to say that we have going on right now is we also have Senate Bill 242, which is to streamline the enrollment process. Currently, it's very confusing for providers and patients and has resulted for some patients in getting mixed up and thinking they can't purchase their medication at various points. And because the current process is the patients get a 3-year card, but they still have to do an annual certification with their medical provider. And people just get confused. They don't necessarily do the annual certification. They stop going to the dispensary. All of these different things. We have worked with patients, especially through the pandemic, to make sure nobody was stopped, that their cards weren't turned off, that they were able to access their medication. And what we have done is, oh, great. Thank you for posting that in the chat there, Eileen. That is great. And what we have been doing is we've proposed a 2-year card. So individuals get certified every 2 years and just see their medical provider at that time. This will streamline the process, reduce all of the confusion between the 3-year versus 1-year certification, and just make it a lot easier. We're going to continue to educate the patients and the providers that this does not mean that a patient only goes in to see their provider once every 2 years. It's really about building that patient-provider relationship and ensuring that regardless of their status in the medical cannabis program, they should be talking with their medical provider regularly, especially if they have one of the qualifying conditions. So we shouldn't be putting bureaucratic and administrative burdens, excessive burdens, onto those individuals. This also will have a beneficial effect, we believe, on the fact that we have a provider shortage, especially in rural areas. So this will mean that, once again, providers are not going to be bogged down just by bureaucratic red tape. And then with the change also to the online system, this is going to make it just so much easier for everyone, as far as for enrollment. Doesn't mean that that we're not verifying enrollments. Doesn't mean we're not making sure that the patients who are enrolling in the program, do not have the qualifying conditions. All of that process is still happening. But we also know that people's conditions don't change that rapidly. And so if they're having that patient-provider relationship, 2 years seems to work very well for most individuals. And we've seen that in a practical way due to what has happened during the course of the pandemic. So that's really all that I have. Oh, I guess I should say we had our first committee hearing last night, and we did get a pass of 6-0. That was out of the Senate Health and Public Affairs. And so now the bill moves on to the Senate Finance. So no date on it though, but if you're interested, if you watch the Senate website, and I'll put the link for the website itself into the chat in just a moment. But if you watch that, you can go to the what's happening, and it gives you a list of what committees and what bills are in the committees, or you can click in the legislation and put in Senate Bill 242, and it'll tell you where it is, at least in the process. So. Okay, any questions? No. Okay, well, thank you, everybody.
Great work.
I appreciate
Great
it.
work. Yeah.
Okay, I guess if there's no questions, back to you, Eileen.
Yeah, thank you so much, Dominic, and also what people may have been able to see that Dominic was referring to is also that in the chat that there's a link to both to the cannabis medical program website, and then where you can also find like the dashboards that he referred to, also the health education materials, things like that could be incredibly helpful. That are incredibly helpful. They could be incredibly helpful to you today, tomorrow, the next day, and then also the link to the proposed legislation. And you know what, I should have asked this. I imagine that you mentioned that the first hearing was yesterday and that this is Senate Bill 242. There's a companion bill in the House, I imagine.
No, actually, they've moved away from trying to do duplicate bills.
Oh, okay.
So what will happen, and the way the process works, is it will go through the committees in the Senate side, then to the Senate floor, and then if it passes the Senate floor, it moves over to the House.
Oh,
So
thank
that's
you.
and then in the House they'll assign it to its committees, and then it'll go through the same process. In the past, they really quite often, and there's still some, but they would do duplicate bills. And what that really meant is it meant that, quite frankly, the legislators were hearing the bills multiple times, and it was taking additional administrative burdens. So they had really asked to really overall, and this started about a year or two ago, to actually try to reduce that down, so that they weren't doing duplicate work. And so there's not a duplicate bill over on the House side. It is just the Senate Bill 242. And once it gets to the House, we'll also have a sponsor over there. We're still working with regard to that. But our sponsor on the Senate is Senator Ortiz y Pino, who is based out of Bernalillo County.
All right. Thank you. That's incredibly helpful context. I hope for others as well, too. With that, before we move on to the next issue on the agenda, and before welcoming the people who are just able to join us, does anyone else have any follow-up questions for Dominic about that? Sounds like not at this time. So then also, before we move to the next issue of the agenda, then would like to be able to welcome the two new people who joined us. So glad you were able to do so. I hope that you both are safe and well with the weather and with everything else, of course, and happy Valentine's Day. And not to put you in the hot seat, but yet here you are. We already did it with all of us. But that if we can ask you, maybe I'll call first on Anna, Hallie, and then next for Gary, that we ask if you could say your name, your pronouns, and then in the spirit of Valentine's Day, chocolate, flowers, or something else.
Well, thanks. I just shoveled my way up to my office and finally got in here. Apologize for being late. Something for Valentine's Day. Well, I'm taking my love to dinner if we can get down our large, long, very hazardous driveway, which somebody else is struggling with at the moment. So happy Valentine's Day to everybody.
Thank you, and glad that you made it. Hope that you stay safe, and happy Valentine's Day to you too. And then Gary, we would love to hear from you.
Thank you, and I apologize. I've been attempting for quite some time to get on and finally have gotten through. And again, my apologies. But for Valentine, well, him, for Valentine's chocolate, but also, sometimes your partner can talk into a bad idea, but it's Valentine's Day, so Valentine's Day wins out. So always save a little room for romance. But again, yeah, should have prepared a little bit better, but I'm glad to be here and sorry for the delay. Thank you.
So thank you so much. We're grateful to have you both. And I think that no apologies at all are necessary. We're grateful that you took the time with all the things that are going on in New Mexico right now, but also all the things that are just going on in life and in the world, right? So we're just so grateful I'm so grateful for all the time that everybody is committing here. And so with that, for the next item on the agenda, as you know, is election of chairs, including the farewell to past members. And I'll turn that back over as well and mute myself.
Sorry, everybody. That took me a moment to get to my unmute button. My cursor disappeared on my screen for me. As Eileen had mentioned, Martin, unfortunately, due to some personal issues, has had to resign from the committee. And so he did submit that to us. And so, of course, that now means that technically we are chairless as a committee. And so we do need to do an election with regard to the chair. So I really think that my question really to everybody is there anybody who is willing to serve as chair for the committee?
Can we nominate others?
You can indeed.
I nominate Eileen.
Okay. Any other nominees? Okay, well, Eileen, would you accept, since you're the only nominee, would you accept the position of chair for the committee?
So one, that's really generous. I feel like I may have inadvertently planted that seed by asking people to talk about chocolate and flowers and pasta that just came up, which I think is also, we could spend all day talking about our love affairs with pasta. I'll confess that I was thinking that of not nominating myself because I feel really strongly in the ability for lots of people to rotate through leadership and to have these treasured leadership positions that provides so much extra context for the good work that's being done in public health. And I really believe in term limits professionally. So I was planning not to nominate myself for that reason. And I hope that doesn't sound too goofy to anybody.
I actually don't think that it sounds goofy at all. My question would be, since it does seem, though, that most people would like for you to serve as chair, would it be fair to say, would you mind serving if we limit it to just 1 year? And in 1 year we do, so that we also honor that idea of having changes in leadership, and so that we honor that idea, if you don't mind doing that. And I personally say it just because I think you have brought a lot to the table, and I was hoping that you would get nominated from my own viewpoint. But what do you think, Eileen?
you drive a hard negotiation. I don't know what it was like to be in your chocolatier shop, but I feel like okay, thank you for thinking of me. And I think that sounds like a balance with, for me, what's like a DEI issue, right?
Right.
So thank you for thinking well of me.
For the record, there was no collusion here between Dominic and me, so just for the record.
And I will say that is true. We haven't actually had a chance to talk since the last meeting, actually. Things have been so busy. So yeah, but thank you, Eileen. And so I do appreciate it. I think the next step then, though, is to give you some support and also to show that additional leadership is now we need to elect a vice chair. So I would, again, I would open this on up. And by the way, the only reason that I'm doing this portion at this moment is because I cannot, as the director for the program, I cannot be nominated or serve in that capacity on the committee. And so that's why I'm doing this, so I can be impartial with regard to that. So are there any suggestions or nominations for vice chair? I'm also really comfortable with silence.
I nominate Hallie.
Who said that? I'll tell you though, I would be willing to serve as vice chair only because I'm very interested in, it's one of the agenda items for today, on how we put this report together and really moving it forward. So I'd be happy to in that regard, be happy to be involved.
And I was going to say, I was going to let things be quiet for just a little bit. And I was going to say, I think also with regard to this is that we set that precedent of making sure that we have this election every year. And so that the positions do change, so that we really just make it for 1 year. So it's not in perpetuity, and that there is that opportunity for additional leadership. So does everybody think that that sounds reasonable? And if so, are there any other nominations for vice chair? Okay, so I think we then have, from unanimous consent with no objections, can you tell I've been sitting at the legislature a lot lately? We have our new chair and vice chair. Congratulations. Thank you both. And then just before I turn it back on over, I do want to say we really, especially from the department standpoint and for myself, really have been very grateful to Martin for stepping in initially and for helping us to get things started and moving forward. And we really wish him the best of luck, and really hope that he continues to be able to do the work that he would like to do. And, we wish him the best and really thank him for his service. We are also getting a letter from the governor's office to thank him. And so I just want to make sure that you all do know that. And, as I spoke with him back in December and early January, he would like to continue to be involved as he can. And so he may show up down the road a little bit, I hope. So thank you. And back to you, Eileen.
Well, thank you. And I'm really excited for the work that's going to go on, and excited also to work a little bit more closely with you, Hallie, as well. And thank you, everybody, for and particularly for taking the time before to have the photo to be able to share with Martin. This is really this is work that really means a lot to him, and so thank you for going with that. And so moving forward, also that excited to hear next on our agenda for us to learn from Haley Peterson. And I'll mute myself.
Hi, thanks. All right, let me share my screen here. And I think once I start the presentation mode, I don't think I'm going to be able to see you all anymore. So if any questions come up during it, I don't mind taking questions at all in the middle of it. Can you all see my slides?
Yes, we can.
Yes,
Okay.
we can.
Thank you. All right. So I'm Haley Peterson. I'm with the Substance Use Epidemiology section here at Department of Health. And today I'm going to give you an update on the Poison Control Center data. We've talked a little bit about it before, so I've got some final 2022 numbers for you all. And then we'll also start talking about the emergency department visit data. So we'll start with that Poison Control Center data. So just as a reminder, the calls to the Poison Control Center can be made by the individual, so by the patient or the patient's caregiver, but those calls can also be made by healthcare providers that may be interacting with patients, like say in the emergency department. These trends are often influenced by external factors. So for example, now that we have an adult use market, the packaging does include the Poison Control Center phone number. So it's possible that people are more likely to call now that they're aware that that's a good option if they're experiencing an adverse event. There's also, we released a HON the day before markets opened back in April. And so that HON was basically to alert healthcare providers that they may see an increase in pediatric accidental exposures, in particular to edible products. So that can push the issue sort of at the forefront of healthcare provider minds. And we requested that they reported those cases to the Poison Control Center at that time. However, reporting is voluntary. So there are some things we have to consider when we look at this data over time. Those trends may change just based on those types of factors. But for the total number of cannabis-related calls in 2022, there were 216 calls. About 2/3 of those calls were related to an edible product, and half were related to pediatric cases in kids age 10 and under. And then looking at the annual number of calls data, so again, 2022, we had 216 total calls related to cannabis, and that was an increase from the previous year. But in general, cannabis-related calls in New Mexico have increased since 2014, which I always find sort of an interesting point to look at because 2014 is when the recreational market in Colorado opened. So I just always think that's sort of interesting to note there. And then looking at the 2022 data, this is by month. So this is just the count of cannabis-related calls by month. We do see that there was an increase in April of 2022. So that's when markets opened. And again, we released the HON the day before. So there could have been some increases just for the fact that we were asking folks to call in. There, of course, could have been increases due to perhaps an influx of newer users that maybe experienced adverse events, perhaps if they were using products that were a bit stronger than they could handle. Also to note, in April, there was that elementary school case that happened, you all may recall, where I believe about a dozen elementary school kids were exposed to an edible product. So that's also sort of a significant chunk of that number in April of 2022. And then we see it sort of fluctuate. Yeah.
Oh, just as a note too, because of that incident, there was also a lot of widespread news stories regarding it. So that also could have resulted in some of the increases that we saw then and then through May, just because it was in the news and very visible.
Mm-hmm. Yes, that's good to know. And so we see there's really a lot of fluctuation here in the numbers over time, but it seems to maybe get a little bit more stable towards the end of 2022. So then this is just the proportion of the cannabis-related calls that were due to an edible product throughout the year in 2022. So we do see that typically from month to month, over half of the calls are related to an edible product. So we want to continue to encourage safe storage. There are some great materials on the medical cannabis program's website on safe storage and safe usage. So I definitely think there's a lot of great education that's out there. So we do want to continue to encourage folks to safely store their cannabis at home, but also harm reduction messaging, that start low, go slow messaging. So people may not be aware that edibles take a bit to kick in. So some folks, might be using an edible product and then saying, oh, I'm not feeling anything, take another gummy, another square of chocolate. And then unfortunately that dosage becomes too high. So that kind of messaging, I think, is really helpful for these cases. And then this is the percentage of cannabis-related calls that were in cases 10 years or younger. So we can see it really fluctuates from month to month here. But overall, again, in 2022, half of the cases were in kids age 10 and under. All right, so we'll move to the emergency department syndromic surveillance data next. So there's, again, more caveats to consider for any data set. So I'll go through that first. So for syndromic surveillance, that was originally intended for infectious disease surveillance. So I think that's always important to point out sort of how this system came about. In recent years, it has been adapted to monitor emergency department visits related to other conditions. So for example, we often look at drug overdose visits in there. Some folks are starting to look at sort of mental health related visits in the Essence system. And the advantage of this is that it provides more timely data. So there's data even 24 hours after an emergency department visit in there. It's not complete at that point, but there, say if we heard of a significant outbreak, but we want to verify it on our end to see if, oh, there actually has been several emergency department visits on Friday or something. We could check pretty soon after that that report came in to see if we're seeing that in the emergency department visit data, but it actually takes a few weeks for it to be complete. So it can be helpful though for looking at sort of outbreak type events like that, but the data gets more complete over time. Some other caveats to consider are that the stability and the number of facilities reporting into the system can fluctuate over time. So the number of, say, hospitals reporting in, it's more complete in the last few years. So in the data we're looking at today, it's more complete in the couple of years that I'll be showing you, but there is still sometimes some fluctuation there. Another thing to consider is it does not include federal or IHS facilities, so it doesn't include, say, the VA. And then when considering the IHS facilities, if we were to look at the data, say by race ethnicity, that's sort of a caveat that we'd have to consider for especially the American Indian population. Another thing with syndromic surveillance, this is intended to provide a rough estimate of the disease burden. So we shouldn't be thinking of this as an exact measure. These syndrome definitions, the one I'm using today is a standardized syndrome definition for cannabis-related visits developed by the CDC and folks at the Council of State and Territorial Epidemiologists. But it acts as sort of a catch-all. So we're going to be seeing visits in this particular syndrome that include things like the abuse and dependence codes, the ICD-10 codes. So the number of visits we're looking at today isn't just the poisoning visits, isn't guaranteed to be a visit that's acutely related to the cannabis use. So this kind of acts as a catch-all. There's also some text-based analysis of the chief complaint fields to consider. So I just always like to give that as a caveat here. And again, these trends can be influenced by external factors. So folks, now that cannabis is legalized for adult use, folks may be more comfortable admitting to their cannabis use when they go into the emergency department visit. So it may be more likely to be noted in their chart. And also providers may be more likely to ask about it because we have the legal adult use market. So it may be more likely to be something they consider as they're trying to figure out what's going on with a patient in the emergency department. All right, so with that, we'll start with some monthly data here. So this is from 2020 to 2022 by month, and this is the total number of emergency department visits. So what I find interesting, let's see if my cursor will show up. I've put some vertical lines here. So this first one is to indicate when adult use legalization took effect. So that was towards the end of June of 2021. And then the second vertical line is when the adult use market sales actually began. So we can actually see in the total number of visits, the peak actually occurs even before legalization took effect. And during 2020, there was a decriminalization statewide, so that might be something to consider. But I just find it interesting, some of the fluctuations we see here. And then we're also going to look at the rate per 10,000 visits. So this is a rate of the number of emergency department visits related to cannabis per 10,000 visits. So we're controlling for the total number of visits that were occurring at the time. And this is important because there can be differences in healthcare utilization. So just to point out, the pandemic has been going on, so that can change, that can fluctuate sort of how people are accessing healthcare services. So in particular, in April 2020, that was when that sort of shutdown was happening. We saw a significant drop in the number of total visits for all causes at that time, but we still see that there's a significant proportion that were happening to cannabis. So perhaps there's a few things that could be going on. Perhaps folks' cannabis use patterns changed sort of at the start of the shutdown. But also another thing I would say is this probably means that if they experienced an adverse event, they didn't feel it was something that could be avoided going to the emergency department. So I think there's a variety of factors to consider here. But again, controlling for the total number of visits, we sort of see perhaps some seasonality going on with access here to the emergency department visits for cannabis. But it seems to even be decreasing in the last few months. So that's sort of interesting. And I think with all this data, markets have only been open since April. We're going to want to keep monitoring this over time. There's still a lot to figure out here. All right, and so now we're switching to quarterly data for the same time period, 2020 to 2022, but we're looking at different age categories here. So just to reduce sort of the messiness of the graph, we're switching to quarterly data. This is again the total number of emergency department visits. So we can see the groups with the highest number of visits are sort of these young adult age groups. So 18 to 25 years, 26 to 34 years, and 35 to 44 years. And this matches what we would expect, especially based on survey data, based on what we've seen in other states. So that's not really a surprise to me that we're seeing those age groups at the top there. All right, and then looking again at the rate per 10,000 visits, and this again helps to normalize for maybe some of the differences in healthcare utilization among age groups. So the 18 to 25-year-olds are still at the top of the graph here. But we also see the 12 to 17-year-olds jump up. And if I had to guess, that's some of that could be that in general, teens tend to be pretty healthy. So they're probably not the highest usage group of the emergency department in general. So when they do experience an adverse event, perhaps, they're still feeling it's necessary to go to the emergency department for those. Their parents feel it's necessary to take them. So it ends up being perhaps a higher proportion of total visits in that age group. But what's interesting too is that peak actually occurs in the first quarter of 2022. So that peak is actually happening, at least for the year 2022, that peak is happening actually before markets opened. So that's kind of an interesting point there. And then to focus in on, I think, the age groups that people have been very concerned about recently. Again, I just sort of isolated the 12 to 17-year-olds and then the 5 to 11-year-olds and the 0 to 4-year-olds. And we're back to the number of emergency department visits. So looking at these younger age groups, I know there's been a lot of concern about unintentional edible exposures, in particular in the younger kids. But actually per quarter, it still remains below 20 visits per quarter in each of these younger age groups here. So we actually haven't seen a significant increase so far in the data. So hopefully that means people are doing their best to safely store their cannabis and, that some of that messaging is getting out there. Again, we do seem to see a slight increase in the total number of ED visits for the teenage group. So that's something we'll want to keep track of over time as well. And then just a last data slide for you all is just switching back to that rate per 10,000 visits, just to control for the healthcare utilization differences that could be occurring over time. So again, we actually see the highest peak in the teens, the 12 to 17-year-olds, occurred in the first quarter of 2021. We see sort of another peak in that first quarter of 2022. So these are kind of some interesting trends, I think, that again, we'll just want to keep track of over time and see what we're seeing here. Like if we continue to see peaks in the winter time, that might be sort of an interesting thing about the seasonality of cannabis use and sort of these adverse events that may be occurring with it. But that concludes the data presentation. Any questions?
Were there any increased uses of emergency rooms in general as things started to move up? I'm sorry, loosen up from the pandemic, so that we might be seeing some increases in cases related to just general use as well. I know it's rate per, but the rate per doesn't tell us the overall use. Right, yeah. So there, certainly during that lockdown, there's a significant drop in the total number of visits in particular in April of 2020. There was a significant drop, but it seems to start to stabilize later on. I do have a graph of the total visits in another presentation I could pull up if you want to see that. But yeah, so there is some variation in utilization over time, but that's sort of what that rate per 10,000 is supposed to help control for. It's not perfect, but it helps control for it a little bit. Right. Mm-hmm.
Ellie, I would just say that in our department meetings, we're sort of back at pre-pandemic levels in terms of emergency department volumes. I would say the hospital volumes overall are worse. I don't know if anyone else working clinically in the hospital has an impression on that.
My clinical practice, our hospitalization rate is very high, though I practice on the Navajo Nation, where I don't have 2 barking dogs, but I do have 2 barking dogs today, so sorry. But that, I'm so sorry, that, you know what, I'll just mute myself and say that I practice on the Navajo Nation where there isn't medical cannabis, so it would be very, very different, I think, than here. But our rates overall are just so high, and it is taking the people who are finally presenting to the ER are usually, they're so medically vulnerable, fragile, and sick. Nobody's using the ER in any way for convenience, which maybe all along was always a myth anyway, and it probably was. But usually an issue of access instead to being able to be seen in an urgent care or primary care. So,
Haley, is this data from? And I apologize if you mentioned this already. Is this from ICD-10 codes?
Right, yeah, so the syndrome definition that's used to pull these visits includes ICD-10 codes. So it's going to include those F12 codes of poisonings, abuse, dependence, but then it also does a text-based analysis of the chief complaint field.
So if cannabis is mentioned in the chief complaint field, it pulls that.
Mm-hmm. Yeah, and it's a very complicated text-based analysis, but it's not just looking for the word cannabis. It's also looking for things like weed and pot and some different combinations of like smoke plus pot, so that it's not pulling, I don't know, where somebody, I don't know, say dropped a pot on their foot or something. Like it's a very complicated analysis.
Does it pull for cannabis hyperemesis?
Yeah, so that would be included in this as well. Yeah, because these are all cannabis related visits.
Thank you.
And Haley, I thought that this was really fascinating also too. And I also, in the beginning, you talked about the Health Alert Network that had gone out. And to me, it sounds like, this is going to sound pretty obvious, but proof of concept that what is put in front of people is the thing that is put in front of them and top of mind. And it makes me think, of course, also about the value of, or the possibilities there, I guess I should say. And I will say that I don't know enough. I practice adult internal medicine, so I don't take care of children. I don't know what are considered the best practices in the 12 to 17-year-old population with regard to what are the things versus that that can affect ER visit rates, because this to me would either be, either they're buying it from their friends or they're experimenting happens at all ages, of course, right? Or that it's a safe storage issue for their parents. That's a little bit different than the kids under 10, because the kids under 10, they of course are experimenting with the world in a different way, and are an access for a kid under 10 versus 12 to 17 is going to be a little bit different. Do you know, or others know, what would I benefit from better understanding for what could be, what would be the role, or what could be the role for the educating the providers about talking with the patients about the 12 to 17-year-olds? Does that make sense? No. Okay. Think of the 12 to 17-year-olds who we're seeing that are having ER visits, and that there's peaks and there's valleys for that, but they are having ER visits for something that that might be able to be preventable. That is, or that, yeah, that we might be able to have a little bit of a harm reduction frame for. Is there anything that you can share with us about, is there a role, what could be the role for reaching out to either the people who are enrolled in the program or the providers who are seeing them to better understand the 12 to 17-year-olds and their access and their ER visits? That probably still didn't make a bit of sense.
Well, I mean, I can say that I know that the Behavioral Health Services Division, with their Office of Substance Abuse Prevention, they in general, work with a lot of county level partners on substance abuse prevention within the communities. And I know that in recent years, especially since legalization passed, they have been adding in specific strategies for cannabis use as well in youth. I mean, I think a lot of the risk factors that lead to, say, alcohol use or substance use or tobacco use, I think a lot of times there's similar risk factors for cannabis use too. So you could argue that in a sense they've been addressing it with their other work in general, but now they do have some specific strategies for cannabis as well. So that I think is good that we've got some prevention work going on. But I agree, safe storage is still important, even though I also think it could be argued that the 12 to 17-year-olds may be a bit more likely that it's intentional use, not, not accidental, like exactly what you're saying. So, yeah, so certainly education on the risks and all that are helpful. But I think, I do think there's an extra complication with cannabis that maybe there isn't for like tobacco and alcohol use, where tobacco and alcohol use, it's definitely bad. It's going to lead to cancer for tobacco, and alcohol, here's all the different harms. Whereas cannabis, I think it can be a bit complicated maybe for youth to understand that, well, my grandma uses it for her pain. She uses it safely. I think sometimes that there can be some complications in how they might perceive it, because it is being used safely by others to treat something. I don't know. That's just a personal opinion.
I mean, it's a personal and a very advised opinion, so thank you, and thank you for hearing what I was trying to say, even though I said it so inelegantly. Good thing y'all are stuck with me being chair, because there's going to be more of that. And I really appreciate your perspective that you're sharing, because I had also lumped in that because alcohol is so much more socially accepted in so many other different formats, and then your point about, but it doesn't have a medical indication that anybody sees that their family member is using. And maybe I'll stop there and see what Andrea was, her hand is raised.
Yeah, I just want to say, so some of you may not know this, but we actually have a 24-hour law enforcement line. So we do communicate with law enforcement, especially on these investigations where a minor's gotten a hold of it. And one of the things we're finding was with the younger kids, it's more about safe storage and the parents not storing product properly. We're finding with the teens, with the conversations we're having with law enforcement, is that it's not New Mexico product. It's product that's being brought in from other states. So it's because they'll tell us what the packaging is, and based on who produced it and that, we can tell that it was not made in the state of New Mexico. So we are seeing a lot of product from Colorado, California, that is being delivered or somehow distributed among teenagers. I'm not saying that the local access does not happen, but a lot of the calls we're getting are that we're finding out that it's out of state. And I do agree with Kelly's viewpoint that, one of the challenges we run into is people say it's, there's been an image that it's benign use of cannabis. It doesn't hurt people. If you talk to advocates, they'll say, well, it doesn't kill people. And, there needs to be some discussion about, the potential harmful side effects. But I just thought it's interesting to understand where the sources come from for a lot of the product as well.
It sounds like when I listen to this discussion, there are a lot of parallels with firearms use, safe storage, safe handling, proper use, etc. I'm wondering if are there sort of parallel laws? I mean, if somebody comes into the ED and their kid has had a cannabis OD, do they then get investigated by Family and Child Services or somebody else? And or are there red flag laws related to this where you can block people from using cannabis in some way, or if they're overusing, that kind of thing? I'm just drawing a parallel now. I haven't thought about it until just now, but as I listen to this, I also have been listening to some of the firearms bills that have come up in the legislature in the last couple of weeks, and the conversation sounds very familiar. Just I guess the emotional component isn't as acute.
So a lot of it, there are some parallels with regard to statutes and law, but the cannabis use in and of itself is not necessarily a reason, for example, for CYFD to become involved. However, if there are any signs, or in the provider's estimation, other signs of abuse and neglect, then they definitely are and are brought in, or can be brought in. And that it is reported. I'm not sure though, and Haley, maybe I haven't actually seen anything where if someone comes in for cannabis use underage, if it's an automatic required reporting to CYFD. I don't believe it is. I believe it's still under the provider's discretion. Do you know?
Yeah, my understanding, and granted, this is in the context of like little babies. So like after birth, I was talking with Susan Merrill, who does a lot of coordination for babies born with neonatal abstinence syndrome. And I was asking her about cannabis, and she told me that cannabis, if cannabis say is on the sort of urine drug screen for the baby, that's no longer like a call after birth. They're not supposed to report that. If the mother was using cannabis during pregnancy, that's not something that CYFD is going to intervene on, is my understanding at this point. But I think you're right that if the provider felt there were other signs that were concerning enough to report it, then of course that's at their discretion. But I'm not exactly sure how that would work for, say, like an unintentional edible exposure. Because I didn't ask about that specifically, but that might be something to talk to Susan Merrill about. She's with our maternal child health group at Department of Health.
Thank you. And that was my impression of it, that it kind of has to have other factors at this point, that by itself it is not a reportable situation at this point. Mandatory reporting, I should say.
Are other poisoning type activities mandatory reporting for, say, a 5-year-old gets under the sink and that kind of thing?
Not to my knowledge.
Mm-hmm. Okay.
Yeah, so I was going to say similarly, if a kid accidentally got, grandma's blood pressure medicine, that's without other concern for neglect or abuse, we wouldn't, reach out to CYFD for that. I don't think cannabis would be necessarily any different from that regard.
Mm-hmm. Okay.
There would have to be something else going on.
Yeah, and I know one thing Susan Merrill mentioned that she, was hoping to spearhead with some other folks that she works with is, for a while with all the opioid funding that was flooding around, there was a real push for lock boxes for people's prescription medications. And so she also wondered if eventually funding could be found to sort of provide lock boxes to folks for their cannabis as well. So that was sort of an idea she had, that that would probably have to come from a statewide effort, since, you know, there's not sort of the federal opioid crisis dollars floating around for cannabis the way that there is for opioids.
But it is interesting because since it is dealt with, none of the other prescription medications, for example, are recreationally available in general. I mean, some are over-the-counter drugs, obviously. In this case, it's sort of a different category in some ways because you have recreational and prescription and medicinal. So, interesting question, at least.
I would also just say, getting back to it, I think Eileen's question was about understanding the presentation of the 12 to 17-year-old group. I think it would be interesting to see how many of those are with a comorbid psychiatric diagnosis. I would suspect that maybe the use is intentional, but also maybe the reason they're in the emergency department is actually that there's, you know, comorbid anxiety or comorbid depression or something else going on, because that's often where I see that cannabis use disorder or cannabis use code is in someone who came in with primarily a behavioral health presentation.
Yeah, and that's something over time that we might be able to, as we get a bit more sophisticated, at least on my end with some of this, might be able to sort of evaluate, you know, is there a proportion of these visits that also have an ICD-10 code for psychosis or something else going on like that? So that's something I can certainly explore in the future.
To step back for a moment and hearing again, thinking some more about what you had said about the hand being sent out. How are those chosen, those topics? It's a little bit different than what we're doing, to make sure I understand.
For the Health Alert Network?
Yeah.
That, I mean, Medical Cannabis Program and we collaborated on that with the Poison Control Center, just because we thought it was an important thing to sort of make people aware of. There's a group at Department of Health that actually sends those out. And so essentially we felt it was important enough to get that sent out, and we wrote one and got it distributed.
And Eileen, it's usually when there are emerging health issues or concerns. I mean, for example, the pandemic, there were, I don't even know how many Hans that went out. But we also do it for things like when botulism cases come up among people who are injecting, if there are strange or different fungal infections that are occurring that we haven't seen before. There were Hans that went out on RSV. So it's really just about issues going on. And what really happened is we were talking about what would be occurring with April 1st and legalization sales starting. It sort of came up, and some of the original came from parallel courses, both internal to Department of Health and with poison control, and also external with some providers who actually then had reached out and said, hey, is this something that could be done? And of course we said, absolutely, more education, the better. So we sent it on out. So.
Thank you, great work.
Well, and I would like to say that Haley wrote probably 3/4 of it. So it was very well done.
Great job. Team, this is a great discussion. What other questions do people have?
Haley, is this data from all hospitals and emergency departments in New Mexico? Is it mandatory?
So there is some fluctuation in some of the months with the completeness of the reporting from the hospital facilities. So it's nearly all, and I believe for most months it is all, but there are occasionally issues with data transmission where I know that I'll see that like a couple hospitals have dropped out. Oftentimes there's some of the smaller facilities. So that's why I included the count of visits and then also the rate to sort of try to control for some of those issues where perhaps for a month or two a hospital dropped out. Yeah, it's just it's unfortunate with sort of the way that the system works. That's just one of the caveats that we have to consider in this specific syndromic surveillance data.
But a pretty complete picture overall, it sounds like.
Yeah, I believe it maxes out at about 38 facilities, so 38 hospitals, but yeah.
Thanks, Eleni. Any other comments and suggestions, feedback, questions? Sounds like no at this time. Thank you, Haley. That was incredibly helpful and very nicely done. Also managing a lot of questions also too. Thank you. And I think that then that brings us to the next part of our agenda, that is the discussion of research and resources. And oh, I inadvertently minimized everybody. Apologies. So Dominic, was this something, or I don't know if Gary, if you're able to unmute yourself, or how we would prefer this next part of the agenda to go?
Yeah, Gary, are you there?
Yes, I'm here. Yeah, I'm not going to attempt to turn my camera on because I'm hanging on by a thread here, it seems. But yeah, one thing I think that we discussed in previous meetings and that we need to get off the ground is creating a template / matrix. And I know that Hallie's been very desirous of this as well, but to create the template so that we can keep track of all the progress and all these numbers, this data that we're collecting. And I'd like to invite you all. We can host it at the Medical Cannabis Programs offices. That's off Rodeo Road. If those in Santa Fe would like to do that, or those from Albuquerque would like to travel. But yeah, I think that we can get this, off the ground and start creating that template. And I don't have a lot of experience doing that, but if there are members that do, please share.
Thank you, Gary, and thank you for, despite sort of your connection hanging on by a thread, you conveyed a lot of information in a short amount of time, and would love to wait out to see what are people's responses to what we just heard from Gary.
So personally, I didn't quite understand everything Gary said. It was an invitation to the offices, but what specifically?
Just to sort of clarify, because in case it was breaking up, is essentially what we're suggesting is that a small group that wants to focus on this to determine what the templates will look like, we would like to offer our offices in Santa Fe for people to come together and to start that particular part of the process, so we can determine exactly what do we want on the template, and kind of move forward from there. Because we think that having that draft and moving, and starting from that point might be better than trying to start on the larger group, trying to figure out, oh, exactly what do we put on in. And so what Gary was saying is, if that sounds good, who's interested, and then we can work to make arrangements as far as dates and times. And if there are people who would like to come up from Albuquerque, we're, of course, definitely very welcome. And if there are other people who are elsewhere, we can connect remotely as well, but we would like to have at least a few people in person. We think that would actually be beneficial to making the determinations of how to move forward. Does that make sense? I said that a lot more complexly than Gary did. But
That's fine. Thank you. I'll raise my hand to be present.
Okay.
Being in Santa Fe to begin with, it makes it easier.
Okay, great. Anybody else who's willing to come and be present? Eleni, Eileen. Okay. Okay, I think that sounds good. And if anybody is interested in joining that, what we'll do is we'll still send the date out to everybody. So if anyone is interested in joining, you can still, this is not the end all be all moment to say, yes, I want to be involved, but realize the date then may end up being one that's convenient for the individuals who have raised their hands. So we'll do our best on that side. So, okay. And I think that was it regarding that.
Well, that sounds really exciting. Thank you so much. And Gary and Dominic, I thought that what you said were perfect compliments to each other. So thank you, and thank you for those who were able to volunteer for this work. And looking forward to everybody's contributions. I think one of the things that segues a little bit nicely into is in general, I don't remember who had proposed it. It may have been Hallie, I'm not sure, or Alan, about having an in-person meeting in general for the committee. And I'm wondering if there is still some interest in that, knowing that it might depend on the time of the year, but knowing that could be some issues with people traveling. Is that something that we should spend a few moments on?
Yeah, I think I suggested it at one point. I mean, I think that this is great that we get together on a Zoom and we see each other's faces once every couple of months and all of that, but we don't really get to know each other. And a better way to do that is to have a meeting where we can actually sit down and talk and have conversation over meals or evening activities or whatever in addition to the committee meeting. It might make sense to do that once we have, say, a template, and then we can all get together and discuss the template as a focus, and then also our process for moving forward with the template after that, because you have data, and then you have analysis, and then you have discussion of the analysis, each one becoming more abstract from where reality is, but also of importance related to policy. So
I think that that's really well said. I wonder if I don't know if Gary's able to unmute yourself, and Dominic, if that sounds like something for us to consider moving forward.
I think it does.
No hard decisions right now.
I think it does. I think though, from what's being said is maybe having that small group meet first, and so maybe have the next meeting still virtually for the larger group, and then plan after the small group has gotten together a little bit for maybe the meeting after that to be an in-person meeting.
Yeah, and then the probability of
completely-
smell will be much lower also.
Exactly.
Yeah.
Yeah, I agree
Okay.
completely with making the template and matrix, sort of getting that step done first. And then we definitely would have a more fruitful meeting the second time around. So I agree completely. Thanks.
Thank you. Anybody with any concerns about that? I feel that's like even more ambitious than I'd expected. I thought it was much later. So great that we have all of you. So does that, I'll ask if anybody thinks, has any other different ideas to say so right now.
Just backing up a touch, are there any lists of general topics that could be thrown out there to kind of give us seeds to start working on to set up trees of topics to be put in?
So I feel like that's a really wonderful segue possibly to the resources and references that we have on the Zotero. And so which I think that could be a really nice conversation. And something in the back of my mind is I loved that Martin had said that when he was previously, he was involved in a group where they did almost a journal club every month, just to have ongoing learning for everybody. And it was brief, but embedded within the meetings. I think that there could be other opportunities there. Oh, sorry. Thank you so much, Dominic, for adding to the chat that very specifically that we do have a charge that is the 8 items that are listed in the chat right now. And then those items, that's also crosswalked into the Zotero that has a series of articles about that fall into each of those buckets, if you will. So with that in mind, I was going to ask if we wanted to pursue implementing maybe this journal club, and also to make sure that people have, maybe I'll back up to see that if people have access to that resource and those references that were shared with us earlier, but knowing that you've also received a lot of emails. So maybe what I'll do is I'll put the link for that into the chat, and I'll ask if anybody has had difficulty accessing that, if they are if they wish to receive some help getting access.
I agree that the Zotero is a good source, yes.
And does are there people who would, or maybe I'll just say it this way, which is I hope that everybody feels comfortable contributing to that. I think that this is a really nice way for us to learn from each other. Does it seem like something that we may wish to do is to select some articles from there and then to have a journal club with our next meeting based on those articles? Maybe just one or two just for a start, and also because of course we have the other business to get to. Does that seem like okay? I see a couple heads nodding. Is there anybody who has concerns about that? Okay, so I'm not hearing any. So with that in mind, and sorry to surprise you about this, Dominic, does that seem like something that that there is, knowing that everybody is busy? Thank you for donating your time. Is there anybody who wishes to volunteer to present an article from there? And again, I think that we could probably save just 5 minutes. I'll say that I feel like I'll do one. Is there anybody who wishes to do a second? And
So
I
Eileen,
yeah.
I will say that I would volunteer, but I have to be honest, with the legislative session right now, it may mean that I fail in that task. But I would be happy to after the legislative session.
Thank you.
This would be for April.
Yes, thank you for that's a great clarifying question. I should have said so.
I can also present one for a few minutes in April as well.
Oh, thank you. Thank you. Okay. I think that probably offline we can decide what those are. Okay. Yeah. And so those are the things that I was thinking for our meeting. What are the things that, besides scheduling our meeting, our next meeting, and then awaiting our follow-up to move forward with the template, what are some other items that are front of mind to you that you would like us to discuss before we schedule? Okay, I just did my count to 10, although I do see that Katie is typing and I'm burning with curiosity to know what it is. Okay. May we move toward choosing our next meeting date? Ah, okay. Thank you, Katie. So if we were to go to the second Tuesday in April, at the same time, that of course would be April 11th at from 10 to 11:30. So I'll throw that out there just for an anchor for us to work around, and ask if you can indicate first if that doesn't work for you.
I will be in Albuquerque at the PIP conference, so I will not be able to attend.
Okay, which conference is that?
It's the Department of Health Partners in Preparedness.
Thanks for doing that. Yeah. Okay, so
And
it sounds
Dominic, are you still on vacation on the 11th?
I was actually just pulling it up, but with the Teams, my thing is going slowly. But yes, I am actually. But what about the 18th then? The third weekend? Or the third Tuesday rather?
Other than it being tax day, but hopefully everybody's more advanced than that, having to do it the last day.
Wait, isn't tax day the April 15th or the 17th since it's a weekend? So we'd be the day after.
You'd think so, but for some reason,
Really?
that's what it says on my calendar. I get a U.S. holiday feed, if you will. So
18th is good for me.
All right with me. Yeah.
Good with me.
It might be a great date for us to have a conversation about chocolate flowers and pasta. Right? And Mateo, it looks like I saw your thumbs up as well. And for people who I can't see, I'll ask if Andrea and Gary, also Libby, would you let us know if that doesn't work for you? Yeah, Gary.
I think that's a great day, and it would actually lend itself to a wonderful icebreaker, perhaps. So the 18th sounds good to me.
Yep, definitely works for me.
Yep, me too.
Excellent. Then I think that we're set. That then April 18th at from 10 to 11:30. Okay. Well, I think then that we might be able to take our egress, and I will ask, actually, maybe Dominic, is there anything else that you wish to share with the group?
No, just thank you, everybody. This was really great, and we appreciate all of the help and, of course, your continued work on this. And Haley, I really want to thank you, because I didn't get a chance earlier, for the presentation. That was really well done. Thank you.
I agree, beautifully said, and I hope everybody.
I'd like to take this up.
Yeah. Oh, Gary, please.
No, I've been sending you all the invitations on Thursdays. We've been doing a little Cannabis Now, Nugs of Wisdom. It's a little forum for our cannabis providers. And I have seen some of you respond, RSVP, that you might be there. But again, I just wanted to share with you all. I'll go ahead and put the invite out again. It's on the 23rd, so it's going to be not this Thursday, but the following. And we typically do it from 12 to 1. And our turnout's been really great. We've been getting a lot of new providers. And so, you know, it's there for you if y'all would love to attend. And also, if anybody would like to present, that is also a forum that we can present at, perhaps maybe some of these articles. But yeah, so I just wanted to throw that out there in case you hadn't been getting the emails. You're all invited, of course.
Thank you, Gary. And that I was able to join for the first time, and there was so much that was covered today. I hope everybody else gets that. Excuse me, on Thursday. I hope that everybody else gets that experience as well. And then maybe we'll let. I'll just again say thank you to everybody. I wish you a happy Valentine's Day. I wish you good luck with your taxes before we next meet, and and also I hope that everybody stays safe and warm. And thank you for all that you do for each other and for New Mexicans. Have a great day.
Thanks, guys. Happy Valentine's Day.
Right.
Happy Valentine's Day, everyone. Thank you.
Thank
Yes,
you all.
happy
Have a
Valentine's
good day.
Day.